Hi everyone. Good morning, good afternoon, good evening. I welcome you all to the seventh episode of Virtual Bariatric University. So today we are discussing a very contentious issue of banding the sleeves. The sleeve gastrectomy is one of the most commonly performed procedures across the world. But the actual Achilles heel of sleeve gastrectomy is the weight regain. Professor Fobi devised a way by banding all his gastric bypass pouches and said that they prevented weight regain. We have applied the same principle of banding the sleeve to prevent the weight regain. At Mohak, we have published extensively on banding of sleeves, and that is one of our standard operations. Today, we have a stellar group of faculties who not only have a tremendous experience with banding of sleeves, but they'll share their data with us and in light of the new evidence. So without much delay, let me welcome you all with our faculties. So first we have Dr. Lemmens. Dr. Lemmens is the pioneer of obesity surgery in Belgium, performing bariatric surgery since 1982. He was the president of the European chapter of IFSO from 2008 to 2010. He was the president of the IFSO EC Congress 2014. And nowadays, his most frequent operations are banded bypass and banded sleeves. I welcome Dr. Lemmens. Then we have with us Dr. Jodok Fink. He's the professor of surgery and consultant for metabolic and bariatric surgery at Medical Center, University of Freiburg, Germany. He's the author of more than 50 peer-reviewed articles on bariatric surgery, and he has done more than 1,000 bariatric procedures. He's also the member of the German Society of Bariatric Surgery. I welcome Dr. Fink. Now we have with us Dr. Manoel Galvao Neto. He is the scientific director at Endovita Institute, Sao Paulo, Brazil. He's also the director of innovation at the IBC Club. He's the affiliated professor of surgery at ABC College of Medicine, Sao Paulo, Brazil. He's a flexible endoscopy committee member at SAGES. He's a bariatric committee member at AFS. And he has also won a Surgical Innovation Award by ASMS in 2015. He was the past chairman of Bariatric Endoscopy Nucleus at Brazilian Society of Endoscopy and Brazilian Society of Bariatric and Metabolic Surgery, IFSO. I welcome Dr. Neto. Then we have with us Dr. Randeep Wadhawan. He is the head of the department at the Minimal Access Surgery, Metabolic and GI Surgery, Manipal Hospitals, New Delhi. He is the honorary secretary of the Obesity and Metabolic Surgery Society of India. He's the EC member and the FALS conveyor at the IAGS. He's the treasurer of the Hernia Society of India, and he's on the editorial board of member of the Journal of Minimal Access Surgery, which is called as JMAS. He has several publications in national and international journals, chapters and textbooks. He has delivered more than 300 invited lectures in national, international conferences, orations in national conferences and CMEs. I welcome Dr. Wadhawan. Then we have with us Dr. Shashank Shah, who is the director at the Lepro Obeso Center. He is also visiting faculty at IRCAD, France, and has been the head of the department and postgraduate teacher for Delhi National Board General Surgery since 2005. He is also a postgraduate teacher for minimal invasive surgery at Pune Hospital and Research Center. He is a pediatric training faculty in Ethicon Institute of Surgical Education, Mumbai. Our next faculty is Dr. Mahak Bhandari. He is a laparoscopic and bariatric surgeon based out of Indore. He's an associate professor in Department of Surgery at Sri Aurobindo Medical College and PG Institute, Indore. He's also the managing trustee of the Aurobindo Institute of Medical Sciences, Indore. He's trained under Professor Fobi and Dr. Bhandari and works as a full-time consultant surgeon at Mohak Bariatrics and Robotics. I welcome Dr. Bhandari. Our co-directors are Dr. Mathias Fobi and Dr. Mohit Bhandari. So without much delay, let's start the program. So now I would like to invite the moderators for the first session.
Okay, so then it's my pleasure to introduce my good friend, Professor Jodok Fink. He will present his 4-year RTC trial of the banded sleeve. As you know, I'm very interested in bending the procedure, and I already started the first, or rather performed the first banded sleeve in 2011, and published the first 5-year results on banded sleeve in 2018 in obesity surgery. So now, of course, I'm very happy that my good results are confirmed by the great study of Jodok Fink. So Jodok, the floor is yours.
Thank you very much for the introduction. I'll just share my slides. Wait 1 second, please. Can you all see my slides well?
Yes.
Yes, perfect.
Yes, perfectly. So thank you very much for that kind introduction. Thank you for inviting me to hold this lecture virtually from Germany, but in fact, streaming from India. So my topic is, why I think sleeves should be banned, and I will try to, show you some evidence for that. And before I really start, these are my conflicts of interest. And before I really start, I'd just like to point out that a regular sleeve gastrectomy without banding is, and this is probably something you all are aware of, one of the most performed bariatric operations worldwide, and especially the most performed bariatric operation in Asia and the Middle East. Also in Germany, I think sleeve gastrectomy today is the most performed bariatric operation. So before we can actually start talking about banding a sleeve, I think we should define what is a good sleeve to us. And I mean, there are these, consensus meetings almost yearly that, try to figure out what's the optimal sleeve. And this publication from already 2011, and nothing really has changed in that, defined the optimal bougie size to be somewhere between 32 and 36 French. And the first firing should begin 2 to 6 centimeters from the pylorus. And I know there is a big debate if you should leave the antrum or not. And I think that debate is not finished yet. So they left it open at that time. But nevertheless, you need to, specify where you want to begin. And the last firing should be a bit away from the GE junction to avoid a leakage up there. And obviously, if you want to create a good sleeve, you need to fully mobilize the stomach, and you need to really take down all the retrogastric adhesions to the ventral side of the pancreas. And especially if you want to band a sleeve, I think you have to be very careful to do this nicely. So now I think I've talked about a standard sleeve, and there are two, I think, distinct problems or facts that led us thinking about banding the sleeves. And one is weight regain or insufficient weight loss. And this is a meta-analysis with 7 and more years follow-up. And if you look at that, we have 7 or more years after sleeve gastrectomy, you have 30% of patients that actually have less than 50% excess weight loss. And if you now look down to the more right-hand side of my slide, you can see that about 13% of all sleeves were revised for insufficient weight loss. And in this meta-analysis, the reason to revise for insufficient weight loss was larger than revisions due to GERD. And none of you probably would argue that GERD is a relevant problem after sleeve gastrectomy, just to give some perspective on what you can expect from weight regain in a sleeve. And the second fact that led us to band our sleeves were good data from banded gastric bypass. I mean, and we have all the experts here. Fobi, you started it, and these are not your data, but nevertheless, they exactly show what everybody shows with the bands, that the banding a bariatric procedure prevents weight regain. And you see the gap opening 3 and more years after surgery. So these two factors, relevant amount of weight regain or insufficient weight loss after sleeve gastrectomy plus good results from banded gastric bypasses, led us to start banding our sleeves. And the only obstacle, if you think about banding something, is all these horrible pictures we have in mind from a classic gastric band. But I think a gastric band has nothing to do with the banded procedure. Here, just as an example, a banded sleeve or a gastric bypass or a banded gastric bypass, you tailor the pouch, you tailor the part of stomach where you put that ring around, and you put that ring loosely around the stomach. Whereas in a gastric band, you need the constant pressure to actually, create the pouch above the band. And I think if you avoid creating that constant pressure, use a small implant, you won't see the same problems as we will see, we did see in classic gastric banding. Now, finally, how would I define a standard banded sleeve gastrectomy? I'd say, well, obviously, you use the same bougie as you would use for a standard sleeve. We in our department use a 35 French bougie. And what we have learned, we want to position the ring as high up as possible, and we now define 4 centimeters below the GE junction as the optimal position, and we close the rings at 7 or 7.5 centimeter circumference. And I personally think that you ideally use a pre-specified implant, whatever you use, because then you repeatedly do the same thing. So now how we do it is just a short video snippet of a banded sleeve. I mean, you see that sleeve now, and I've tried to show where we put it, and we obviously try to spare the left gastric vessel. And then there are basically 2 basic techniques to put in the ring. One is perigastric, that's what we use, and the other one would be pars flaccida. We go somewhere through there, but we try to spare all the vagal nerve branches here, not to cause any problems with that ring, and then easily, pass the introduction of this implant alongside the dorsogastric wall, and then, close it. And this specific implant here allows you to adjust, but I mean, there are a couple implants out there, and some of them allow for the same. And right now, we always close it at 7.5 centimeter circumference. I know, look, you do it a bit differently. You also use a bit smaller sizes, but as of now, we mostly use 7.5. And if you look at the final picture, you nicely see how loosely that implant lies around that sleeve. Sorry. Now, what's the evidence? There is a couple of short-term evidence out there. One is our study with the very short-term evidence, and the other one is the Italian study. And both of them show that there's not much difference early after surgery, but that's something we just expected that way. And the major issue to actually publish these short-term outcomes to us was that we wanted to show that there was no harm when banding a sleeve, and we could not show in any of these papers there was no added early or added operative complication. So there are 4 retrospective studies to date with up to 5 years follow-up, and 2 randomized controlled trials with obviously prospective data with a follow-up up to 4 years. So I want to just quickly walk you through each of these studies. Look, this is your study you initially mentioned, and look, could nicely show when comparing banded to non-banded sleeves that obviously there was a gap in weight loss, and that gap in weight loss was mostly due, and this was what I like most about this study, this gap in weight loss was mostly due to a lesser amount of weight regain in the banded sleeves. 2 in the bandeds versus 20% weight regain up to 5 years after surgery in the non-bandeds, obviously resulting in a better weight loss in the banded group. And this is Mohit's study from India, and they could actually basically show more or less the same thing. They also showed, a lesser amount of weight regain in the banded group, And in addition to that, in at least the Mohit study, there was extra initial weight loss. So in this study, the gap in weight loss came about as, less amount of weight regain plus extra amount or extra initial weight loss. And our study was a bit in between. Our study was a bit in between, showing a bit of extra initial weight loss early after surgery, and then the gap opened 3 to 5 years after surgery, showing better weight loss for the bandits. So all retrospective trials we have basically show a very, very similar picture. Now, how about prospective evidence? We performed our randomized controlled trials with 94 patients that were randomized in a 1-to-1 ratio, and quite, tightly followed them and had a good follow-up 3 years after surgery. And we managed to get almost all patients back. And looking, this is probably the key picture. It exactly, mirrors what we saw from our retrospective trials. You see a bit of extra weight loss early after surgery, and then a lesser amount of weight regain in the follow-up, finally resulting in a difference in excess weight loss of 11.6% in this prospective trial, mainly including patients with BMI around 50, but not limited to. And I think this is not only significant, I think 11.6% 3 years after surgery are also clinically relevant. And this is the other randomized controlled trial from Italy. And well, the result, in fact, are quite similar. Again, you see better weight loss for the bandits, but in this study, the better weight loss in the end, 3 years or 4 years after surgery, basically was caused by a better initial and continuing weight loss in the bandit and group, and not so much due to a lesser amount of weight regain. Now, obviously, the ring causes better weight loss, and this is, uniformly shown in all these studies. How about complications? So I think one of the most relevant complications when you talk about sleeve gastrectomy is reflux. And I tried to put all the studies in one slide here, and Luke didn't report any reflux, neither did Mohit. And in our study, reflux, in our retrospective trials, reflux was not much different. The reflux symptoms were not much different in between bandits and non-bandits. Whereas in our prospective study, we could show that, and you look at the blue is the the red is the bandit and the blue is the non-bandits, we could show that the ring was even a bit protective of clinical reflux symptoms. And I don't want to sit here saying that if you want to prevent reflux after sleeve gastrectomy, just bend the sleeve. But we were more concerned of the opposite, that it might aggravate reflux. But I think all data to date show that this is not the case. And to be extra safe in our randomized control trial, we tried our best to rescope our patients 3 years after surgery. And I think the development we saw was quite interesting. There was a fair amount of patients with reflux esophagitis preoperatively, obviously only low-grade reflux esophagitis, otherwise we've done a bypass. And most of these patients actually improved or went to remission during follow-up. And then there was another group of 20 to 30% that developed de novo reflux esophagitis. But that, again, was not different between bandits and non-banded sleeve. So also, with scope data, we could show that, banding a sleeve definitely did not do or not have any negative impact on reflux esophagitis. Well, the only, to me, relevant side effect of ring implantation we saw was regurgitation. Luke saw about 7% of regurgitation in his bandits, whereas our retrospective trials saw a very high rate of regurgitation more than once a week, around 40% 3 and 5 years after surgery. And if you look down to a prospective trial, this heavy regurgitation, more than once weekly, went down to about 15%. Still was significantly more with the bandits, but that's probably something we expected. But it went down from about 40 to 15, and the only thing we did is we changed ring circumference from 6.5, which we had in all of our retrospective series, to almost all of our retrospective patients, to 7.5 in the prospective setting. So I think this is one important message, that if you want to prevent regurgitation after banded sleeve gastrectomy, don't close that ring too tightly. Now, coming to a conclusion, I think today, 2020, we have we have 2 randomized control trials, high-level evidence that shows better weight loss when banding in a sleeve. And both of these studies, including all retrospective trials, show that there's only a small percentage of side effects to us, but this is mostly my personal opinion, it's mostly regurgitation. The only downside we have to date is that we have no true long-term data. And taking all this together, I'd say that the banded sleeve gastrectomy to date is a bit underestimated and definitely an underused procedure. Thank you very much for your attention. Are there any questions? Luke, could you unmute your mic?
Okay, I'm unmuted now. Okay, sorry. So again, great presentation, great results. We all know the good results now of that, and it's amazing that if you compare your results, my results, Mohit results from different parts in the world, they're more or less the same. And we have complete different eating behaviors. So that makes that the banding the sleeve is really consistent, and that the results are really consistent. So I had a few remarks. I agree. We also changed now with the rings, and we mostly put the ring on 7.5 centimeters because of the regurgitation, and that's a difference in what I published at that time, because at that time we mostly did 7 centimeters. Now also we changed to 7.5. Second thing is where to put the ring. You showed us to put the ring at around 7 centimeters from the EG junction. I try to put it now 2 centimeters higher. The lower, and I think it's a take-home message for all people who want to start with, because it's easier to put it lower, but you will have more slippages. And I've seen in the 9-year follow-up now I did, that I had some slippages, and every time when the ring was a little bit low, my assistant did it from time to time, and then we could see that then there is a more chance of slippage. We had a few migrations, but only in sleeve. I think it's 1%, less than 0.5% of migrations. Mostly when you see them, it's in redo operations, because when you do a sleeve after, let's say, a lab band, and then I think we had one and then another one also, and those are primary without any, and we don't know the reason of that one. So this is another remark. And then another thing is what I call functional stenosis. And these are patients complaining about regurgitations, and when you do all exams, you can imagine everything looks normal. And then when you go inside, you see that the band is fixed into the liver. And when my idea is then when the patients are sitting up, of course, or standing by eating, that the liver hangs on the and brings the ring a little bit down. Maybe that's an explanation, I don't know. Then we put some fat in between at that time. And some will have at the long term some stenosis. And we don't know why the ring is on the right place, but some patients will make a lot of fibrosis around silicone. And that's what we have seen is that I had some stenosis on, let's say, under the ring. So we at that time, or we open it and take some fibrosis out, or we take the ring out at that time. But I think it's, I don't know, because in your study you already have seen those let's say complication side effects, because we did now also with the bypass more or less the same results on the long term and the same side effects. So thank you very much. Because sorry to take so much time, and maybe other people have also questions, or.
Yeah, I'm happy to answer all the questions. I mean, I fully agree with Luke. I think you should put the ring as high up as as possible, and we aim for 4 centimeters. I mean, sometimes it's 3, and I mean, obviously, everyone is afraid of all these vessels up there, and I mean, you have to make a choice. But I aim for 4 and try to go up as high up as possible. You don't have to, if you go too far up, I think the pouch is getting too small. You have no effect anymore. That's what we see when we, secondarily bend a small pouch bypasses. It doesn't really, add a lot of restrictions. The pouch has to have a certain size.
I agree. Somebody else, or some other questions? No?
Okay.
Okay. Thank you.
Thank you so much, Dr. Fink, and thank you, Dr. Lemmens, for this. And now I would like to invite Dr. Wadhawan to please invite Dr. Mahak Bhandari to present his case.
Thank you, Vinny. And the outset, sorry for the lighting, it's going on and off. I'm honored to be here, and thank you, Professor Mal and Dr. Mohit, for inviting me here. I have immense pleasure in inviting Mahak Bhandari, who's an associate professor at the Science, Indore, and also is working at the Mohak Bariatrics. And of course, he's got an excellent pedigree. He's the brother of Dr. Mohit Bhandari. So we would love to see, and we would love to hear him speak about all the work that they have done, Mohak has done in the field of banded sleeve gastrectomies. Mahak, please.
Good evening, everyone. So I'll be presenting on the comparative outcomes of banded sleeve gastrectomy versus the normal sleeve gastrectomy. So I bring greetings from my institute. Above is the medical school where I work, and below is the Mohak Bariatric and Robotics Center where we do all the surgeries. So I have nothing to disclose, but Dr. Mohit Bhandari is a consultant to J&J Medtronics Bariatric Solution. And Dr. Fobi is the founding president of Bariatric Corporation. So we do a variety of procedures. Till now, till July, we have done around more than 13,000 cases, in which we do a variety of procedures like the sleeve gastrectomy, the gastric bypasses, the OAGBs and ESGs, in which there could be a banded and a non-banded procedures, with robotic and conventional procedures. So this is how we started our journey. Like from 2010, we started with sleeve gastrectomy. Then in 2011, we started with gastric bypasses, then the OAGBs. Then we were getting the patient with weight regain. So we started banding the patient. So we started in 2011, the banded gastric bypass, banded sleeves, and the single incision surgeries. And till now, we are doing all the procedures which can be robotic or endoscopic also. So as the background, the laparoscopic sleeve gastrectomy is the most commonly performed bariatric operation done everywhere. But we do get complaints of inadequate long-term weight loss. So this is the common problem because it happens due to the sleeve dilatation. As you can see, I have just put up the pictures in which you can see a normal sleeve here. But by the time a dilated sleeve, after 4 years, you can see a dilated sleeve here. So we were thinking of how to maintain the weight. So we thought of adding or reinforcing it with a ring or a band around the gastric sleeve, which was proposed. So we did a study of a banded sleeve versus a non-banded sleeve. So the procedure-wise, what we do here, this is a standard sleeve diagram in which we do a transaction of the sleeve from 1 to 2 centimeters from the pylorus, and we make a sleeve of width 2.5 centimeters with a 38 French bougie. The length of the sleeve goes up to 15 to 20 centimeters, and the volume is around 75 to 150 cc. So this is the X-ray showing the dilated sleeve over the years. As you can see, the sleeve has been dilated over the years. So this is the main reason for the failure of the sleeve operation. This is the intra-op picture. As you can see, the sleeve has been dilated over the period of time. And now this is a procedure of the banded sleeve in which we do a transaction 1 to 2 centimeters from the G junction, and we again make a width of 2.5 centimeters of sleeve on a 38 French bougie with a volume of 75 to 150 cc. The band is placed around 3 to 5 centimeters from the G junction, and the band size can be 7 or 7.5 or 8. The common band, it can be a normal silicone based band or a handmade band, or the band from other companies like the Fobi's ring or the minimizer ring. So the till date, we have done around 3577 procedures in which the conventional sleeves are 2529 and the banded sleeve are 1048. In which from the sleeves, the laparoscopic are 2299 and robotic are 230, and the banded sleeve are laparoscopic 902 and robotic are 146. So when I'm doing a study, what do I have to compare? I have to compare the weight loss outcome, the metabolic conditions like the diabetes or the hyperlipidemia or the other conditions which to be compared of a banded and non-banded sleeve, and to analyze the early post-operative complication, the long-term nutritional effects, and the quality of the life of the patient because of the adding of the band. So the comparative outcome, the data were prospectively collected from both the cohorts. The data which I have used in this particular study is a matched cohort. The patients were divided into two groups, the banded and the non-banded groups, and they were analyzed according to the weight loss outcome and the weight regain. So this is my data. As you can see, I have matched the cohorts. The laparoscopic surgery, I have taken the number as 152 and banded as 68. As you can see, the age, the male to female ratio, the body weight, the BMIs, I have matched the data so as to compare. The patients had in the banded and the non-banded group have also matched, but in the laparoscopic sleeve gastrectomy, there were hypertension of 45.4% in the patients, while in the banded it was 36%. Rest data is the same. So this is a follow-up. We have got a very good follow-up rate of 64.4% in the normal sleeve gastrectomy and 70.5% at 6 years in the banded sleeve gastrectomy. So this is a very good slide. As you can see that we are comparing the percentage total weight loss outcome of the banded and the non-banded group. So below is the normal sleeve gastrectomy. As you can see, at the end of 1 year, there was a total weight loss percentage was 30.59. In the banded sleeve, it was 32.31. But as the time grew, and then at the end of 3 years, you can see the banded sleeve, the percentage total weight loss outcome rose up to 39.9%. But in the normal sleeve, they were regaining the weight. So from 30.59, they went up to 28.19. And over the period of 6 years, as you can see, the banded sleeve patients had a weight loss outcome of 36.28. And in the normal sleeve, it is 20.3. What I'm trying to say in this particular study is that any procedure, if you will do a sleeve or a bypass and banding the procedure, the main thing, every procedure, there can be a weight regain. But what we are trying to say is that the weight regain, what happens in a non-banded group, it is too much compared to the banded group. So as you can see, there is not that much weight regain in a banded group. But as you can see in the normal sleeves, it was 30.59 and it went to 20.3 kg, 20.3% after a period of 6 years. So they tend to regain the weight. Then the excess body weight loss percentage, as you can see, on a period of 1 year, the banded group was 74.17%, and in the non-banded it was 73.68. Again, as you can see that again, as the time passes by, the patient tends to regain the weight, and it went up to only 50%. But on the banded group, there was a weight, not that much of weight regain. So it was up to the 82.85%, and at a period of 3 years, there was a maximum weight loss of 90.57%. So the basic thing is that adding a band to the procedure means the weight regain is not that much, and the patient is also happy because they don't complain of weight regain. So there is a term known as weight maintenance, which happens in a banded group. Now, for the failure, we call the failure as if the person has regained the weight, and the failure is known as less than 50% of the excess body weight loss if he has regained the weight. So as you can see in the laparoscopic sleeve gastrectomy, there is a weight regain of 46.9%. So this is a very bad failure rate with sleeve gastrectomies. Now, nutrient deficiencies after a period of 6 years, as you can see, not that much, because in the sleeves also, the hemoglobin is the same, in the banded also it is the same. The protein deficiency or the vitamin deficiency, they all are the same. So it means that whether it is a banded procedure or it is a non-banded procedure, there's not that much of nutrient deficiency in the sleeves. This is a slide which shows the resolution of the comorbid condition. As you can see in the banded group, there is a good resolution of diabetes, hypertension, and dyslipidemia. And food tolerance, yes, after adding a band, there is some problems, but the patient are not that bad in tolerating the food. So it went up to 60.8% in the banded group. And the operating time is just 3 to 4 minutes more, because just adding a band, creating a space in the perigastric area and adding a band and suturing it with a non-absorbable suture material doesn't take any time, but it do need some experience also. So now I'm just quoting some studies. This is the study which has been done in our institute only, which is a banded versus a non-banded sleeve, a 5-year outcome. This shows that the banded patients had tolerated a very good weight loss, but the non-banded had a weight regain at 2, 3, 4, and 5 years post-operatively, and the banded group had more weight loss than the non-banded group. This is the study, again a study by Pigeonot and Leslie. Again, it shows that the banded sleeve gastrectomy shows a better weight loss outcome. The only thing can be a regurgitation, but there was no major impact on the reflux symptoms after the use of PPIs. This study is done by Dr. Lemmens only, in which he had shown that the non-banded group had a weight loss, had a weight failure at 5 years as compared to the banded group. So again, he had matched the cohorts also. Again, there's a study by Solomon, in which again he has shown that the curve of the weight loss was steeper in the banded sleeves, and the weight loss was remarkable in the banded group. So to conclude, a loose filling band around the sleeve can be a very good procedure for the sleeve, for the banded sleeve, as it tends to just make the patient feel very good, because there is no weight regain after a period of time, and also it is a cost effective thing, but still the band is costly. So further studies are required to address the cost effectiveness of the approach, and the addition of the band can increase the total expense of the surgery. Thank you very much.
Thank you, Mahak, for your presentation. Excellent presentation. Enjoyed your presentation. We all know that the Achilles heel of a sleeve is almost always either a regain of weight, dilatation of the sleeve, or it is GERD. So these are the two aspects which we've been addressing for a long time. And dilatation of the sleeve or weight regain can be addressed by putting in a band. And we have done our own work as well. We have a 4-year data which also shows somewhat similar results. By the end of 2 years, there's a difference in in the excess weight loss, and then it becomes statistically significant from 3 years onwards. And by 4th year, there's definite difference. Even then, the people taking up or doing banded sleeves are a lot less, and which is the surprising fact. And I just feel we still do not have enough data to show the value of putting in the band. In fact, I was looking at some of the literature, and I found that a systematic review by Parmar, which was published December of 2018, which is just about 2 years back, and he looked at all the data, and he found only 238 banded sleeves, which included by Dr. Fink and Dr. Luke Lemmens and all the papers which had been published till then, and just about 238 cases. So I just feel there's still a lot of apprehension about putting in the bands there. The other thing I find is the rate of complications. Putting in a band and the complications, though you have presented or your own work where you do not have had the erosions. Luke has presented his work where apparently there were only 4 cases where there were some issues regarding the band and they had to go in again. But by and large, it's reasonably safe. Particularly what you just mentioned that putting in a loose band, say about 7.5 centimeters is what is kind of ideal, rather than going for a very narrow band, which we all do. The other thing which is extremely important, and I want your answer on that, is GERD. Now we know there is de novo GERD, which actually goes undiagnosed. In fact, there is enough data to suggest that at 5 years, if somebody is to do a scope, we may find asymptomatic GERDs in almost 12 to 15% people. And in fact, about 8% people may have actually a Barrett's esophagus, where they are completely asymptomatic. Scopies have been done, biopsies show Barrett's esophagus. Now the fear amongst a lot of people is that this may aggravate GERD. Though of course, Dr. Fink just presented that actually it improves GERD because obviously there's no fundus there. In fact, no less dilatation of the fundus, and maybe obviously there's no de novo GERD or lesser after putting in a band. What is your opinion and what is your data? Do you actually scope these patients at 5 years? When you presented your work at 6 years, did you scope these patients? Did you find there is an excess increase in GERD, or you felt only it was because of the symptom complex that you feel that the GERD did not increase? So, yeah.
So I'd like to add that from last 3 years only, we have started doing the post-op endoscopy for all the patients. And for as far as our data is concerned, I personally think that adding a band reduces the GERD because of the ring thing only. But we have to create a paper just as to see a long-term follow-up. This is my view on the putting a ring there. But yes, because the doctors, if they are not comfortable in putting the band, they were doing some tight sleeves. That was the main reason for the GERD. But as I said that we should make a very good sleeve and we should put a very slightly light loose band. So as it should just give a feeling that just there is some fullness. And that too, it should be around 4 centimeters from the G junction, not that much nearer to the G junction. This is the only thing which I would like to add, sir.
So at the end of 5 years, your data basically says that there is no increase in GERD. It's only because of the symptom complex. Endoscopies weren't done at the end 6 years. So endoscopy weren't done at the end of 6 years. So that's one. Two, what are your indications? I mean, you still do the regular sleeves. So what are your indications where you would insist that this patient should actually go in for a banded sleeve rather than a non-banded sleeve?
So the main indication is that first of all, the price thus matters, because putting a band, it increases the cost for the patient first. Second, if I am knowing if there is a high BMI patient whom I find the liver is cirrhotic, and then I cannot do a stage procedure in that particular patient, so I would be recommending a banded sleeve patient for that particular patient. Thirdly, if I feel that this patient, he's a super obese, and if he cannot, like he's from a lower socioeconomic class, and or by the time or over the years, if he's not able to take that particular multivitamins, or if he would be lost to follow up, then at least a banded sleeve would work best for him. These are the indications for a banded sleeve, sir.
There's a question which has come in the chat box. Handmade ring made of NGT or JP drain at 7.5 centimeters. Does it do the job? Any issues with it? Please let us know. So any experience of using anything else apart from the minimizer?
No, sir. We have used a Ryle's tube for a handmade ring, putting in a proline inside that. We have not used this other tube, the JP drain. But yes, the silicone material is there. So we have not used that particular JP drain for that thing. But for the handmade thing, the Riles 2 works good for the patient.
Any questions from the other moderators, the other faculty?
Maybe one remark for
Yes, please.
concerning the self-made rings, because in the very beginning I did a few of them, but we are discussing about 6.5. It's only half centimeter difference, and it's very difficult to close to do a handmade on the correct way. So at the end, if you pull a little bit more, the ring will be much closer, and at the end you don't know what you are doing. And I think I'm really in favor of these rings, because then you are sure you have the right size.
Be with you over there, so that it's best to have those measured size rings rather than just at arbitrarily using Riles tube or anything else. I completely agree with you there.
I would comment that at Mohak, with about 2,000 banded procedures, we see more problems with the surgeon-made rings compared to the prefabricated rings.
Thank you, Professor Fobi, for that. So that pretty much answers the question that it's best to use the rings which are pre-made and commercially available rather than using your own NG tubes. Thank you very much. So if there are no more questions, thank you, Mahak, for your presentation. We enjoyed it, and thank you once again.
Thank you so much, sir.
At this time, we'll go ahead and invite Dr. Manoel, Neto, Galvoa, the endoscopist, the surgeon, the innovator, to tell us how he intervenes in problems after banded procedures. Galvoa, you have the stage.
Thank you very much, Mo. It's an honor to be here. And I'll give you a perspective of an outsider. So pretty much, guy, I judge your rings when they come to me, and I'll declare my bias on that. So I don't see your beautiful results. I say, but when are you guys or the patient comes to us and we identify problems of the ring. So I think I will share my screen with you. Oh, and can you please tell me if you can hear me and you can see my screen?
We can hear you, but we cannot see your screen.
Good. So that how to deal with issues with the ring by endoscopy. So that's my reach. And most of our appearance will be about the banded gastric bypass. So the banded sleeve, most of the problems we see with rings and bypass, they are on a critical, like a critical mass of patients with an 8 years old. So banded sleeve doesn't reach that yet. And you just heard and see the initial discussion on handmade fabricated rings. So let me tell you and show you left and right here. That's the anatomy. On the left, you have no ring. And on the right, you can clearly see here the impression of the ring outside. And we will press on the right, and you're going to see the anastomosis. So that's the anatomy that we look when we see that by endoscopy. And you saw here, we see the ring on the right, and we need to see a channel of at least 1 centimeter to the anastomosis. And if it is a banded sleeve, this ring should not alter the axis of where the scope passes to. So what we have been developed on that. Let me see if I can pass here. So that's the anatomy I wanted to.
Having some technical problems? Unmute yourself.
The host muted me. So I have to get back to my presentation. Was not me.
All right.
I'll got
All
back
right.
here.
Himanshu? Thank you.
So you have my image again?
Yes.
Yes.
So I hope, Mao, you like what you see.
Yeah.
So that's here. We're trying to get our connect. So you can clearly see here the components, the anatomical components one should. So this have to be on the axis. You have to see the impression of the ring, and then you have to go and see the anastomosis. So what are the complications that are reach of my endoscope? So you can see here, the most commons are the ring erosion and the ring migration. So I call erosion and migration, the terms kind of confuse in English language, but basically what I see is that I see prosthetic material inside the lumen, and I let you choose the name you wanted. Okay, to me is the same. So let's see here. We have been working a lot on that, and because Professor Fobi has inspired a generation of surgeons in my country, and until 10 years ago, 90% of the gastric bypass in my country, they were banned. And you see that Brazil is the second most largest market of bariatric surgery, so we have a lot of bans. And again, it's not that the band has a higher rate of complication, those rings have complications, is that the numbers were great. It was very big. So we end up dealing with quite some of those, and we even have some publications, ending up that we have to develop our own Caesar, endoscopic Caesar. And why I say that? Because on the market worldwide, you used to have the Olympus Caesar that is a suture cutter that doesn't do the job, and then we developed our own that you can see here on the screen. And now we have the company called Apollo. They have a very good Caesar also to deal with that, and that's important because this is a thick material and you need a cutting power on that. So I'm going to show you here the two types of situation that we face. So you can see here on the right side is the passage through the bowel into anastomosis, and you can see here the migration with a fistula, a gastrojejunal fistula, but you have the exposure of the ring with more than 25%, and you're about to see it right now. In that case, we use single channel scopes, and we are able to pass this, it's a 2.7, 2.8 millimeters. So you can see you open, it's very important that you engage, that you put inside the lumen, and with your scope, you exert pressure and then a lot of pressure to cut. And you're gonna see here the cuts like butter, and you see those are handmade rings. Once you cut it, gonna be the easier part. You have a forehand body that you can grab this ring and you can remove. And one thing that was not mentioned that I want to mention to you, so if you're doing a ring removal and a bypass, please go after the fistula, because there is quite significant amount of time that you have a gastrogastric fistula, gastrojejunal fistula on that. So what we did, we put inside the lumen, then you remove, and you're gonna see here that that magic comes. Also, don't be concerned of any kind of leak of fistula, because the ring that didn't migrate it right now, it was migrating, so there is a blockage of the abdomen on that. So you can see here the fistula, and you can see here I'm going to go to the right passage of the scope into the anastomosis. So the next one, the next situation is where you have minimal migration. So it's a little bit more complex. You need a double channel scope. You can see here very minimal exposure of the ring. So for those kinds of situation, what we use a double channel scope in a kind of a surgical technique. So for one of the channels, we'll pass the scissor, and on the other channel, we'll pass a grasper. So with this grasper, we're gonna grab the ring and pull it inside the lumen with pressure, also pulling, and then we're gonna rotate a little bit, as you can see, so we expose a little bit more. And as we rotate the scope to the right, you see that we engage in the scissor, and then we can just cut as we already apprehend the ring. So the job is easier. So you cut, once you cut, you just remove the ring that you already have there. So it's basically, if you are well trained, it's a 10-minute procedure, and all of those were done under sedation on that. And that's it. The other situation we face with the rings is that those rings, they can dislodge over the anastomosis, causing an outlet obstruction. They can dislodge over the sleeve, causing a torsion on an axis deviation on that. And you can see here, you can call this ring slippage. So please pay attention to those images. You see that on the drawing, the ring have going down into the anastomosis, causing an outlet obstruction. And instead of seeing a direct path of the scope, the arrow on the middle drives your attention that the stoma, the passage to the bowel, is deviated to the right side and upper. And it's interesting that when you have a slippage, adjustable gas band, the image is exactly the same. And also you see here the image on the middle, that you see food retention. If you go to the X-ray, you're gonna see that the ring is on a vertical shape, as you can see. So we have faced those situations, and also a lot of those patients comes from open surgery time. So to get back there and take the adhesions and take the ring, theoretically is easier, but what we see from surgeons that they send the patient to us. And then our group developed some approach to that. The first approach was to aggressive dilate these with an achalasia balloon dilation. With pneumatic dilation, we can reach 20 psi, is a lot of pressure. So we published that at that time, working together with Josenberg Campus. And you can see here good publications and how it goes from your left to your right. You put the achalasia balloon, we like the Rigiflex balloon over Savary guide wire, and you can see here on the X-ray how we can basically rupture this ring. The downside of this is that we're gonna really dilate the pouch itself. We're gonna dilate the anastomosis, so basically the patient can regain weight on that. And that was a publication on gastrointestinal endoscopy on that. I can show a little bit to you how it's done. So we use a specific balloon, not because we have any conflict of interest, but because it fits what we need. You see here the pump we used to do that. And this animation will show you the dynamics of how it happens. So the ring slides over the anastomosis, causing an outlet obstruction on that. Sometimes it's difficult to pass the guide wire. And you face a situation, my dear friend surgeons, that the surgeon is loving the situation because they are so skinny, 18 BMI, 17 BMI, cannot eat anything. And they say to us, oh, don't dilate that much, and blah, blah, blah. But we see that the patient is on a malnutrition situation. You have to go there inside. So you see here that you can see here the stoma, how deviated it is. And even part of the bowel was kind of inside there. So it's slipped over the bowel right now. So it's a very, you have to be very precise on passing this wire. We use X-ray to see not just the passage of the wire, and also to see the waist of the balloon as we apply pressure. So we can see here direct vision and also X-ray, and we apply pressure on the balloon. You can see here we are passing the wire, and you can see that the scope is just inside the ring from inside. So pay attention to the upper left. You're gonna see here the ring until we lose this waist, and sometimes you even, or you enlarge it or you dilate it. So take a look of the endoscopic image, the paleness where is where the balloon is inflated. Now is just after we dilate that, so you can see. But we saw and we seek for another solution. And another solution was based in the index paper, where they put an old lap band, the shorter one that is very tight, and they were able to put a stent and induce the migration. So with that inspiration, we started using stents to induce the migration of those rings. So let's see how it goes on that. And at that time, we used these plastic stents from Boston Scientific. Again, no conflict of interest. They are the only one who do that. They don't do that anymore. Now we use the metallic stents cover. So you can see here, there's a patient that even the shape is not bad. So we can see here the pouch, the impression of the ring, and then you go and see the anastomosis. But these patients couldn't get enough solid food and protein for that. So basically what we do is that we guide wire, and then we pass the stent. I'll let you there. So if you see the X-ray here, we are in this. Sometimes it's hard to pass the stent. It's a tight turn on that, but you can manage to pass that. So let me show you how it is. And you can see here right now the ring itself, and we are opening the stent, and you're going to be able to see how it fits on the stent. Interestingly, you should not put the stent on the esophagus. So it had to be on the pouch. So the patient basically not feel some pain, but not going to feel discomfort, a lot of discomfort. So yeah, open up the stent, as you can see here. And let me tell you at the end, because it's okay. So clearly, you can see here that you have the stent and the ring is already being dilated. But just look inside of what we have. So we're gonna pass the scope, and you can see that we are able to see the ring by transparency. So there's a lot of radial force pressuring the stents. So possibly what we do is by pressure and ischemia, and you can see here, so just here the stent is, so on the pouch, not on the esophagus, but you can clearly see the ring as the stent compresses the wall on that. We will see that better, like, so we are inside it. But now check, you can see here the ring outside. So with no more than 15 days, you go back and you remove the stent. So you can see here the stent is fully distended. We can easily pass into the bowel. And also we can see for transparency the ring. So what we do, we go there and remove the stent. And you're about to see some magic. I don't know, Mao, if you have ever seen this. And my friend Luke, if you have ever seen that, but it's beautiful to see. Very beautiful. And I just want to see your faces when this come out. So what happened is, sometimes the ring comes with the stent, sometimes it milks the ring inside the lumen. You have to get back and get there. So we are taking the stent out. And when we get inside, so surprise, surprise, that's the ring. Looks like magic. So you remove this, and different from the balloon dilation that you're gonna lose your restriction, on that procedure is a little bit different because you're gonna see the amount of tissue reaction for that. And around up to 20% of those patients will have stenosis that we need to dilate 1 or 2 times. So it means you see here that tissue reaction on the anastomosis. So this will cause a little bit of stenosis, keeping the restriction, and then we are able to dilate if we need on that. So I think it's a more elegant way to deal with those situations. And then when it comes to banded sleeve, I personally don't have experience. I think I have removed 2 of those fabricated with the scissory design. It was not a big deal. But is this a different ball game to us? No, it is not. The difference is you don't have anastomosis, and instead of having an outlet obstruction, you're gonna see that it will rotate the axis, and it will cause a dilation of that pouch. And sometimes if you let the patient with so long, this upper part will be the same when you have a stenosis of sleeve gastrectomy and an axis deviation between the body and the antrum. This upper part will be get a lot of compliance, and even if you remove, sometimes it's not enough. It's not enough to recover the motility on that. But let's see here a case from the Mohak team, and you see here the upper GI. So you see that you have a pre-pouch dilation, and you see that the passage is a kind of not narrow, but you see that is a repercussion outside when you compare with the sleeve itself. And you see here that possibly it is dislodged downwards, because just after we pass the ring impression, we are in the middle of the sleeve. So you see it's a little bit low. And on top of that, there is an erosion, a minimal erosion. And you're gonna see here, Mohit with lots of technique. He grabbed the ring that was a little bit exposed and migrated. And with the endoscopic scissor, he was able to cut most of this. Is a very thick one. So he will cut on that. And at the end, there's still some suture over this handmade ring that was not able to. What he did, he exposed until you can see here the notching element. And as he was not able to handle with the scissor, the suture, what he did, he's just touched with APC, argon plasma, and it opens like this very easy. So again, you see that once he finished, he was able to pass. And again, there is fibrosis, and it's not gonna cause any kind of leak or something like that. So see here, it cut, and then it's time to remove the ring. And I hope you could get of that. I hope you have like that, and I'm here to clear any of your doubts on that matter as much as I can.
Thank you very much. We would move to the surgery, and then after the surgery, we would come back to the panel discussion. Dr. Matu?
Thank you so much, Dr. Lemmens, Dr. Manoel, for a nice presentation. I would now like to invite our second chair of sessions, Dr. Luke Lemmens, Dr. Fink, and Dr. Randeep Wadhawan, who will be moderating the live surgery session. So we have with us Dr. Shashank, who will be presenting the case details first, and then we move on to Dr. Mohit, who will be demonstrating the surgery. So Dr. Shashank.
Good evening, everyone. Today we have a 35-year-old female with a weight of 126 kg and BMI of 47.12. She is a vegetarian by diet, and she has other comorbidities of osteoarthritis. She has no GID symptoms. In the blood profile, the albumin is 4.0, HbA1c 4.88, non-diabetic, and COVID-19, HbA1c, HIV negative. USG showed grade 1 fatty hepatomegaly. Thank you.
Okay, so hello everybody. Hello from the operating room. Can you hear me? Dr. Fobi, Manoel.
Very clearly, yes.
Okay, so good evening, Luke. Good evening, Jodok. Good evening, Dr. Fobi, Dr. Wadhawan. I hope all of you are doing good. As a first step towards this procedure, we always perform an upper GI endoscopy, and we do it intraoperatively. So this is the scope inside. What we basically want to verify is the gastroesophageal junction. If there is any problem with the gastroesophageal junction like esophagitis, hiatus hernia, or other issues. Can you help me with some air? So this here is the Z line. I don't see any esophagitis here. Looks okay as far as this is concerned. Once we go inside, we also see if there is a hiatus hernia. So the G junction here is exactly at 39 to 40 centimeters. This is the stomach. I am not seeing any specific pathology in the stomach. We go and trace the pylorus. Although in all these cases, we understand that we are as such not going to violate the stomach in a way that we leave any remnant which causes a problem if we have a pathology later on. But still, I am going to do a little bit of work here for you. So this is basically the first, second, third part of the duodenum and the jejunum. And once we pull the scope back, we're going to see if we have any ulcers. So to me, everything is looking fine as of now. There are no ulcers. I do not even find duodenitis. It looks normal. Now we can retroflex this scope. And you see this is very nice hiatus. I do not have a problem here. Very small, but I don't see that it's of a concern as far as a contraindication to sleeve. So looks good. Probably one of the perfect cases to do sleeve, and that's what we want. We want some of the good cases where we can perform and justify a sleeve. And as Dr. Fobi has mentioned a couple of times, we do have an algorithm at our center, so we do not perform just the sleeves only. We perform all different kind of procedures. The case mix, as Dr. Mahak explained, is all three. Sleeves, bypasses and MGBs are all in equal numbers. We banned most of our sleeves and most of our bypasses because our data suggests that the results in the long term are much better. Now, how to start the procedure? So let me show you my port position. So we have other participants from across the world, and almost 100 people are watching this live on the LinkedIn. So this is the optical port. We use the varus needle to create the pneumoperitoneum, and just because we have paucity of time, we just put the ports. So this is just above the umbilicus. I am standing on the right side of the patient, my assistant between the legs. So this is the optical port, which is the first port which we put just above the umbilicus, and it is 12 mm. Then we have a 10 mm port, which is in the anterior axillary line, and this 10 mm port will then become the optical port. So the concept is that we shift the optical port from the midline supraumbilical port to the left side in the anterior axillary line. And then in the mid axillary line, we have another 5 mm port for the purpose of retraction by the assistant. I have one 5 mm port just below the subcostal angle in the anterior axillary line here for my retraction for my left hand. So in total, we have 4 ports for the sleeves, as you can see, and one of the 3 mm liver retractor, because we want to give a non-traumatic liver retraction. I start exactly opposite to the incisura. We can shift to the endoscopic view. So when we start exactly opposite to the incisura, the advantages, we enter into the lesser sac very easily, like you can see. We entered here, and then this is the incisura here. Then the dissection will continue towards the caudal end. Once we have enlarged this space a little bit, and why we are doing towards the caudal end is because when we go to work towards the area of the spleen and the G junction, we have a very good exposure if the caudal part of the stomach is perfectly mobilized. So this is the trick.
Mohit, can you hear me? Can I ask a question?
Yes, please go ahead. You can.
Hi, Mohit. We've already discussed this before. This is just for the sake of the audience.
Yes.
This was, so a few questions regarding the endoscopy. This was the first endoscopy for the patient. That's fun. Number 2, you used air or CO2. Number 3, just in case this patient had a large hiatus or a gastroesophageal reflux, though the history would have been taken, but anatomically, if you found that, would you have changed the procedure, number 1? And if you had changed the procedure, has the consent been taken, the patient been informed? So just these questions for the sake of the audience.
Yes, so the first part is that yes, we take a very detailed consent that this is the first endoscopy, so the plan can change, and we explain the patient our algorithm, that this is the algorithm of the center and the plan can change on the table. So they basically give consent for all types of procedures. We tell them that the possibility that we have to change the procedure is very less, but there are situations when we have to do, and that you have to sign a consent for, and they are all happy doing that. Now, if suppose I find a hiatus hernia, I use a carbon dioxide, period. We never use air last so many years. And that's the reason why Professor Fobi wants me to demonstrate. Every time I do an intraoperative endoscopy, I demonstrate the bowel, it is never dilated. So which means that the carbon dioxide is perfectly absorbed as far as we are concerned, and that does not create any problem in doing an intraoperative endoscopy. So that part of your question is answered. I recommend surgeons to use an intraoperative endoscopy, if they do carbon dioxide, because air takes a long time to get absorbed. Now, the second part of your question, yes, if I find a large hiatus hernia, and large to me is defined as something where the defect is more than 4 centimeters, I never do a sleeve. I would go ahead and do a gastric bypass, and obviously I will band the bypass. So that's the second part of your answer of your second question, that if you find a hiatus, would the plan change? Yes, the plan would change. And we have seen that the patients are very satisfied, because these patients, they would say that the reflux has virtually disappeared after the surgery. So obviously gastric bypass is the choice if we have a hiatus. If we have a small hiatus, say 1.5 centimeters, and the defect is not pronounced on laparoscopy, those are the cases where I would not do anything. But they have to be less than 1.5 centimeters. But if we have a pronounced hiatus on endoscopy or on visual inspection, like you see here, the crus is nicely visualized. We have no defect here. So I am not, inclined to, dissect it furthermore. This is a good dissection here. I can see the left crus. I can see here that I have completely mobilized the gastroesophageal ligament. And this part of the dissection is sufficient enough. We need not go here and dissect more and create a new defect, because I don't feel that that's something which we in any case need to do. This kind of dissection here is sufficient enough for us to sort of continue with the procedure and say that, okay, now we can go ahead and do a sleeve. I have seen some surgeons dissecting too much in that area. I usually do not do that. So that's fine. That's the defect. Now we ask the anesthetist to come in with the bougie. Can you bring in the bougie, please? Just before that, before the anesthetist comes in with the bougie, I would like to just rotate my stomach towards the roof of the abdomen, just to see if there are some adhesions with the pancreas. So you can see these are the adhesions there, and that I remove. Now, anesthetist with the 38 French bougie, we have the same size of bougie available in India. So I do not use any other size of the bougie apart from this. Keep pushing, keep pushing, keep pushing. Don't be afraid, keep pushing. So this bougie is usually placed into the first part of the duodenum. We would love to have it into the first part of the duodenum, and if we are a little more conservative, we can still keep it inside the stomach, but I usually put it into the first part of the duodenum. Now the advantage is, this is the pylorus here, this is the duodenum, and you can see I am just holding the bougie with the duodenum. So this is the duodenum, this is my pylorus, and this is 2.5 centimeters, which means this 2.5 centimeters and another 0.5, 3 centimeters will be the distance from the pylorus. And that's what we usually keep. At the same time, participants and other surgeons may recognize that this is a gap which I keep with the incisura, so I do not go very close here. But this is the area which is the most dangerous area, where Manoel gets all these dilatations and his work goes on. So, this is very tricky. If you sort of go more close here, I usually see that we face problems. So this is the area which if you can avoid, that's the best. Now,
so Mohit, how far away from the pylorus?
So as I said, 3 centimeters. So this is 2.5 and another 0.5 centimeters from the pylorus. Now I'm going. Now you can see again I keep this distance. This is the dangerous area. So I again keep this distance. I do not go close. Yes, just because I don't want to give any business to Manoel, and I remain away from that area. But you can see that at the same time, we are not that loose with the tissue. So we acknowledge that, and also I can use this ruler to measure it. So if you see this, just turn it. So yeah, okay, this is good. So you can see that my breadth of my pouch is 2.5 centimeters uniformly everywhere. So we start from here, and then see the pylorus. Let's see the distance from the pylorus. So you see 3 centimeters which I measured for you. So 3 centimeters from the pylorus and 2.5 centimeters the breadth of my pouch. The gastric tube can now be pulled back a little. So we have the tube in the stomach. Can you pull it back? Now what is the advantage of doing this? this gives me a little more mobility of the tube so that I can, just have the tube exactly at the lesser curvature, because sometimes the tube being into the duodenum, it does not gives you that mobility because it is in the duodenum. So after the second fire, my trick is that I pull this tube back into the gastric tube. So this gives me more mobility in terms of manipulating the tube whenever it is required. Now, as you can see, we have reached to the last but one stapler, and this is important for most of the surgeons who are doing their first sleeves. We are not very tight or very abut to the bougie. The bougie for us is just a rough estimate. As I said, we measure it with the scale, and by the visual perception now, we do realize that that's around a breadth of 2.5 centimeters. I'm just going to take this vessel because this is a pad of fat here. I don't want to damage this pad of fat with a vessel in it while I'm firing the last, hopefully the last stapler. Now, this one is a question asked whether you mobilize the pad of fat. Can you just retract the lever for me? Whether you mobilize the pad of fat or not. So I usually refrain away from mobilizing this pad of fat. I just retract it. And my distance from the GE junction, as you can see, would be around 1.5 to 2. So this is my GE junction here. I'm not gonna, go very close, but I remain at least 2.5, 1.5 to 2 centimeters. You can see this is my GE junction. I remain around 2 centimeters away from that particular area. So, which means that I'm not very close to the GE junction, and the possibility that I would damage it with either an energy source or either my my stapler is going to be less. Now let's measure the length of this tube. So let's see. This is my tube, and let's start from here. So that's you can do that way. Anything. Okay. So this is starting from here to here is around 10. Okay, let's start from here, this place. And then it's another 17. So 17 centimeters is the length of my tube which I created. Now the breadth is around 2.5 everywhere. Now we pull the tube back. Now how to create this space? So the trick is pull the tube back, Okay. Now the benefit of pulling the tube back is that I again get some amount of area where I can actually manipulate my bougie, and I would try to put this tube not very low, not very high, but around 2.5 to 3 centimeters, above below the G junction. So that's the area which I am trying to target. Now if you see, I am dissecting it so that I do not enter into a false plane, but I dissect it under vision, and now I see that there is a space which I entered. Now let me put the ring inside so that I can demonstrate where I fix this ring. So this is the ring here. This is a minimizer ring which we are using. I have used the gap key ring. We have used the minimizer, as Professor Fobi said. We used some surgeon-made rings, although we had more complications with the surgeon-made ring. But now we are having only this ring available in the market, so we use the minimizer. The benefit being you can calibrate it on table like you're doing it now. This calibration is important. So here is a size 7.5 which I'm using, size 8 which I'm using, and this now I can cut. So you can see that there are slots. So this is 8.5, this is 8, this is 7.5, and that is 7. So that's, this ring is made that way, and we can cut both the ends here. This ring also has a benefit of a socket being used to help us fix this ring. Now I will fix the ring, and then I will show you the area where we have inserted it. It should be around, let's take a ruler first. Let's take a ruler. So let me take a ruler for all of you to show you where I exactly position the ring, which is important. This is the esophagus here. So you can see I am exactly 2.5. I would say 3. What do you say, Abhishek? Just go a little. It's 3 centimeters. I would say 3 centimeters below the GE junction. So that's the area where I prefer to fix it. I can go through this here. There is a socket there, and then I can, now here also I don't take a very deep bite, just take a superficial, just through the staple line, not going through the stomach tissue too much. As you can see, I don't want the non-absorbable suture to be inside the gastric mucosa, which can increase the possibility of an ulcer later on. So that's it. We fix the ring here. It's 2.5 to 3 centimeter below the G junction. And now I can cut this. At this time, you can see the bougie is still inside. So Dr. Dikshit, just show the bougie. Just Abhishek will show. Okay, so you can see, just push it. Okay, push. Okay, so you can see Dr. Dikshit is moving this bougie, and let me show you something. This is how loose the ring is around this particular stomach pouch, even with the 38 French bougie in. Now, Dr. Dikshit, remove the bougie. So he's completely going outside, and now you see this is a very loose sort of a ring around the gastric tube, which I have. Now let me do some hemostasis. So we have been asked this question as to how you do hemostasis. I don't suture. I don't believe in suturing till the time we have certain special situations, but we are very effectively using the clips at our center, and all of us, including Dr. Fobi, we follow the same protocol. Even when he operates, he's also using the clips. Initially, I think we were doing some sort of a suturing, but now we thought that maybe putting a good clip is a very nice option. And you can see this is, you require good assistance there. So my assistant is pulling the staple line, and I go exactly at the base of the vessel to apply it. I see when people use clips, they are not successful in hemostasis because they do not have either good assistance or they do not apply it at the proper area. So what we need to do is just go at the base and just give a little bit of retraction and then apply it like I'm doing. So clip application needs some retraction of the staple line very softly, and we just go to the base to apply it. This is the area of the sleeve which bleeds the most because there is a lot of fat here, but it's fine. Okay, so this is what I have here. I can now put some additional clips wherever it is required. So we usually would not leave the patient till the time we raise the blood pressure to 140 mm of Hg. And now you see this is the clip, and there's the base where we applied it. So it takes care of the oozing, small oozers. And this is the same method I've used as over Mahak mentioned. We did around 4,000 sleeves at our center. So we have used the same method every time to take care of this oozing. Okay, if there are any questions, I'm more than happy to answer.
Yes, thank you for that very nice procedure. I have one question regarding the clips. I mean, I also use these clips, and I'm always, a bit afraid of what I do when I revise. You also remove them before you do the revision? Mm-hmm. When you do the revision?
Okay, so I never had a problem with these clips while I was revising. Never. In fact, we have revised these sleeves which have failed to banded gastric bypasses, MGBs, duodenal switch, SIDEs and other procedures, even re-sleeves, but we never had a problem with these clips.
Okay.
I never use clips, or nearly never use clips. I just coagulate on that, and I never had problems with that. I never had a fistula with that or whatever.
Yeah, Dr. Luke, you have operated at Indore, and we had that opportunity to learn. If you remember, you were at the same center from where I am telecasting around 10 years back, remember? Yeah. And I saw your technique of coagulating the staple line. So that's a good technique, but I think we use clips if required. We have done that also. I think Dr. Fobi also uses the monopolar, but Our generation of surgeons are using more clips than these. But I agree, I never had a fistula. None of the surgeons who used that had fistula.
Mohit, excellent presentation. Just that we generally go for the ring, we go a little, you went about 2.5 to 3, we would probably go at 4, just so that getting near the left gastric, just a little fear over there. So what's your comment on that?
See, Dr. Fobi taught us that the more distal you go to the GE junction, the more are the chances of increased reflux, because the more you go, the volume of the pouch proximal to the ring increases. And that's the thing which causes reflux. So most surgeons who report reflux after a banded sleeve have it because they go too distance, lot of distance away from the GE junction. And that's why they have a large volume of pouch proximal to the ring, and that reflux is increased because you have a lot of reflux then, because there's a large volume of pouch to reflux. The first. The second is that if you go more distal, you have a chances of having hourglass, and that hourglass can cause a functional or a mechanical obstruction both. Number 3, most of the ring displacements or slippages we have in our series are when we had it placed more than 3.5 centimeters below the G junction. So I would recommend place it 2.5, at most 3. I know that there's a fear of left gastric artery in place, but if you dissect very close to the stomach pouch, usually you should come out clean. Maybe Dr. Fobi can express more because that's what he taught us. I mean, I was the same. I used a pars flexita technique, and I was way below down, almost 6 centimeters. And most of these revisions I did had been those cases because we had more slippages, more problems, and more reflux. Dr. Fobi can explain more.
Well, basically, you want to follow Laplace law. The smaller you make the pouch, the less likely the pouch is to dilate. And the smaller you have the pouch, the more the patient will have a full sense sensation when they eat food. When they eat food and it comes down to where the ring is, it lodges there, distends the esophagus, and the patient has a sense of satiation. And like Mohit said, the more distal you put the ring, the more likely you create a pouch that will dilate, and the more you might have reflux, and the more you're likely to have slippage. But that was an excellent demonstration. From the endoscopy to the end of the sleeve gastrectomy, we took exactly 31 minutes. So you can do a banded sleeve in a very short time. At this time, we'll turn it to go on to the rest of the panel. We are right on time, but I would like Jodok to comment on the surgery he just seen. Dr. Fink?
Yes. Well, as I said, I think there was a lovely surgery. The ring was placed just, as we would do it. I personally don't use a ruler, so I always measure my instruments before, and then I kind of estimate, but probably also around 3 to 4 centimeters. And Mohit was even up higher. We also use the clips, so this was a sleeve just as we would do it, and I love to see that type of surgery. And I think Mohit pointed out all the important details of what to take care of. So excellent work.
Yeah, it's one of the reasons this is the virtual bariatric university. This course is intended for young surgeons, and you, the experts, are therefore going to demonstrate these techniques. And rather than have people just say, I make a pouch this long or I make it this wide, we want to demonstrate the pouch and measure it so to see objectivity. We have to bring a certain amount of objectivity. For instance, I'll give you a time when you listen to surgeons who do a one anastomosis gastric bypass, and they say, we'll make a long pouch, 20 centimeters long. Well, the length of the pouch is dependent on the height of the patient. So just because you make a pouch does not necessarily make it what you say it is. And the size of the bougie does not determine the size of your pouch. So you have to objectively show that relatively the diameter is below a certain amount. So we want to give them some objectivity, because there are many surgeons who say, I use a size 32 bougie, and they will transect the pouch 3 centimeters away from the lesser curvature. And they're saying one thing and doing the other. So we're trying to teach young surgeons that we can standardize what we do and therefore have better results. Thank you very much. Luke, do you have any comments about how the surgery went?
It was a very nice procedure, of course. I used the Signia, the reinforced stay press, so that's why I see much less bleedings than at the end of the operation, at the end of the procedure. And on the rest, I do the same thing. I fix also through the stapler line, and it's really important not to go into the stomach, because when you make the knot, not make the knot too tight, because it will cut through the stapler line, and that will can cause a leakage. But on the other hand, and then maybe one remark, and the big advantage of the banded sleeve is you don't have to make the sleeve too small, too tight, because the tightness is because of the ring later on. So, and then maybe, as you mentioned already, the Laplace law, that the fact that the sleeve is less tight, that maybe there are less fissures also. So that's another advantage of the banded sleeve, I believe. So, but of course, it was great surgery. Thank you.
Well, at this point, I'll just make a few comments. The principle of the banded operation is to prevent dilation of the pouch, which is part of the natural history of any pouch. Any patient who has gastrointestinal surgery, even when we did the GI bypass, we noticed that with time, the small bowel dilated. There were small bowels I went into where the small bowel had dilated to about 10 centimeters and the colon had dilated. So the body has the ability to stretch. When you put a ring there, the stretching is limited to where that prosthesis is. And so you retain three mechanisms: the restrictive mechanism, the full sense mechanism, and the force compliance. When you do a sleeve, whether you band it or not, the patient has been instructed to eat slowly, chew their food thoroughly before swallowing, and take small bites. So all surgeons instruct their patients to do that. So in the first 6 months to a year, the patients follow those instructions. They chew their food, they take little bites, and they eat slowly. With time, that pouch will stretch. Patients who follow the compliance you instructed them to will do well, and they will not gain weight. That is why you have surgeons reporting that I have a patient with a dilated pouch, but they didn't gain weight. That is correct, because some of the patients follow your instructions. They eat 3 times a day. They take a small portion. They chew it well, and they eat slowly, and they stop when they feel full. But most patients with this syndrome obesity, they eat till they can't eat anymore. So in those cases, they will stretch that pouch, and as the pouch stretches, they would eat more and they would defeat the operation. So putting a ring there controls that subset of patients who eat too much, and the ring is not there to be obstructive. As Dr. Galvoa has shown, that ring has an indentation you can see by endoscopy, and therefore the idea of banding the sleeve is an excellent one. Dr. Bhandari, I was waiting for you to see whether you have any comments, and we can go from there.
Yes, so I think one of the reasons we do banded sleeve, because the data is suggesting, and I think now we have 7 years, the data is suggesting that the results are as good as mini gastric bypass without these deficiencies. Yes, there are certain ring strictures and certain complete obstructions which we had, but they are all with the surgeon made rings. I know Luke is not in favor, and so is Jodok not in favor of using the surgeon made rings, and I agree with them that they have more complications. In India, we have a certain population which is not very privileged, so we use those rings because we believe in the principle. But as Dr. Fobi said, that your complications can increase. First, if we do not follow certain principles of very small proximal pouch, perigastric technique to insert the ring, proper material of the ring which has to be used, mostly a non-surgeon made pre-sterilized prefabricated ring by a company,
So if we do all these things, the results are better than the sleeves, the non-banded sleeves for sure. I mean, there's no doubt about that. At the same time, since Manoel is also here, I don't know the protocol at other centers, but those surgeons who embark upon banded procedures, even bypasses or sleeves or anything, they should learn endoscopy, because that is something which is required for 3 reasons. First is that we would want to document, because this question comes to all of us very frequently, that sleeve already, the Achilles heel of sleeve already is a reflux. Now, if you add a band to it, are you adding insult to the injury? And we have no answer, because answers will come only if we look for it. So Dr. Fobi decided that no, we're not going to sit like that. We will endoscope all our banded sleeve patients. And I still remember that when we were endoscoping the first 15 or 20, he was there with us to see if we are really doing our job correctly. So I think we should endoscope these patients from 1 year until 4 or 5 years after a banded sleeve. And we should see the GE junction. We should see the dilatation of the esophagus, whether it is more or less thinning of the esophagus. We should see what is the situation of the ring, whether there's a ring indentation or there's a stricture. Or we should also see if there is a lot of food residue which accumulates proximal to the ring. These are the things which one should observe while doing these endoscopies, and then we can compare if there is more esophagitis, more reflux, more Barrett's with banded sleeve as compared to the non-banded, and then that data has to be put in the database. So this is one that you should be able to do good surveillance. The second reason for endoscopies is obviously if we have an erosion and patient complains of sudden epigastric pain, these rings can be managed very easily by using special scissors. Manoel already demonstrated that, and he gave me that very stout, very strong scissors. Normally the scissors which comes with Olympus or Boston Scientific or other companies, they're not as strong and as stout, but this company made that scissors which is very stout. You can easily cut the ring and pull it out. Other method could be that if there is a very small, less than 10% of erosion, is to put a stent and have a complete erosion and then pull the ring out. So basically we should know that for surveillance and for treatment and for management, bariatric endoscopy should be learned by surgeons rather than being dependent for these privileges. I know the privileges for countries differ, and sometimes there are no privileges, so we have to be dependent on gastroenterologists, but then they need to have some knowledge upon how to manage these ring erosions. These are not like adjustable gastric band. So lithotripters won't work here. We need good stout scissors, we need stents, and we need good experience of bariatric endoscopy to understand how we need to do the surveillance and manage these complications. Also, as Professor Fobi said, that the diet counseling is very important here. I think we should sit with these patients for their meals when they start after 3 months, the solid meals. I think Luke must have sit with a patient who had a banded sleeve and how these patients eat. If we sit, it is very interesting. My banded sleeve patients, they are not able to consume that volume of food and that speed with which a non-banded sleeve does. So by 3 years, a non-banded sleeve would return back to almost normal eating, whereas a banded sleeve patient still keeps on vomiting if he does not follow the tenets of banded sleeves. Slow eating, chewing multiple number of times before they gulp it down, completely masticating the food to small pieces before they take it in, and eating frequently rather than eating a large meal at one point of time. So these are my points. Bariatric endoscopy, patient counseling, and patient expectation building is very important. You need to tell them that you cannot behave the way a normal sleeve patient does 3 to 4 years after a banded sleeve, or else they come to your clinic with food bolus obstruction and problems. These are my only submissions.
Therefore, one remark.
Go ahead, Luke.
On the erosion of the rings. So, okay, the frequency is very low, less than 0.5%, same in the bypass and same in the sleeve. Okay, I think the best thing is still to cut the ring and take it out, but putting a stent inside, okay, you can do that eventually in a sleeve, but be careful if you do it in a bypass, because if you put a stent and there are no vessels left below the ring, then and you put a stent and you take the ring out with the stent, then you will have fibrosis of the distal part of the small part of the parts below the ring, because there is no vascularization at that place, and then you have to go back later on because it will make a stenosis, and you can dilate and stenosis again because the length is too long. So especially in bypass, try to cut the ring and take it out, and don't let it migrate completely. I think that's an important remark. I've seen it once, and they have to be reoperated later on to do a lower gastrectomy.
Yeah, my point of putting a stent was only in reference to a sleeve, not for a bypass. Yeah, I converted some of these into surgical cases, and Dr. Fobi knows about it. We had some very bad ring strictures with the surgeon-made rings. So we converted them into a Roux gastric bypass, removal of the ring, resecting the cicatrized tissue, like we do in the adjustable gastric band era. This cicatrization was a little more stronger to cut to. It's not easy if we have a stricture with the surgeon-made rings. So I would recommend to use, as far as possible, the company-made rings. A company-made ring can erode more, but they won't cause strictures like the surgeon-made rings does.
Let me also make a comment. I mean, we just conduct a study regarding eating habits after bandits and non-banded sleeves, and I fully agree with what you said. They eat differently, and they also consume different types of meat. We have not really seen a bit difference in vitamin deficiencies. However, our bandits hardly consume any meat. I mean, they basically eat carbs and vegetables and not that much meat. So I think there might be a bit of difference in vitamin deficiencies, but as far as now, we have not seen any. But eating habits are definitely different.
Yeah, the eating habits are different, and I had this criticism for one of the MGB surgeons. So he is so the MGB surgeons always, because I am on that group, so they always complain, and this is why I wanted to bring this. Randeep is here. There are other MGB surgeons. They say that, you know, when you do a banded sleeve, you force a patient to cheat, because then the patients go on a soft calorie diet because he's not able to take the Mediterranean type diet like salads and fruits and things like that. So Dr. Fobi always explains that that's the part of the counseling we need to do, that you have to chew this food. You have to keep chewing the food till the time you can gulp in. And that chewing the food also causes early satiety. So I believe that the MGB doers say that they have a procedure where they change the diet of the patient from sort of a lot of a fat-based diet to a Mediterranean one, and that is not possible with the banded sleeves because it's very restrictive. But at the end of the day, I realized that these patients with MGBs had a lot of weight regain, and then finally I had to resect their pouch and put a band and do a banded MGB. So then they did much better. So I for sure know what is going on, because I have been doing all the 3 procedures, and the patients initially would shift to a Mediterranean sort of diet, salads and all. And go back to their, you know what, MGB is not as malabsorptive as duodenal switch. So that concept of forcing the patient to eat Mediterranean and eat as much as he wants and still get a weight loss is actually a farce. At the end of the day, we need something very strong, very restrictive, which forces the patient to change their habits.
So
What is
Mohit, I
amazing also that the patients that don't complain, not always, but most of them that don't complain, and if you don't ask what they are eating, they will tell you they can eat everything, they can go to the restaurant, but they learn to eat, to live with it. And most of them that don't complain, and that's amazing. That if you don't ask really what they are eating, they come and tell you, okay, I'm happy, I can eat whatever I want. You see, that's why it's so difficult. The difference between some patients who regurgitate and other ones who won't regurgitate. You really have to ask them what they can eat. Otherwise, you will not know. That's why it's so difficult to say if there is some patients more vomiting than other ones. They will not tell it to you.
Yeah.
Well,
Yeah.
the only way you can evaluate it is how many patients with a banded procedure come in there and say, I want the damn thing out. Very few. As a matter of fact, I have patients who came in after an erosion and they were upset when I took out the ring and they say, put my ring back. I can eat all I want right now, put the ring back. And you know, it's difficult to go and put in a ring in a patient who's had an erosion. So it's kind of difficult to counsel them, but I had to do it in a couple of patients. But what Luke says is very important. I am a patient who has a banded procedure. All of you who work with me at Mohak, you go out to brunch with me and you know I have the hors d'oeuvres and I stop there. I chew the food. And if I really want to eat any steak, I eat it privately because I chew it and sometimes I spit out the chaff in a napkin because I don't want to swallow it because I don't have that tolerance. But that is the price you pay to have the weight loss and the weight loss maintenance. It doesn't make sense to say, I'm going to give a patient an operation where they can eat all they want and lose weight. If the patient can eat all they want and lose weight, that's when they have the malabsorptive problems. The beautiful thing about the banded gastric bypass and the sleeve is I reviewed the literature and there has not been one death attributable to the ring in more than 30,000 cases that I've seen in the literature. Whereas if you do a malabsorptive procedure, you're looking at a mortality of about 0.2 due to the malabsorptive, the protein caloric malnutrition or liver failure, and even patients with liver transplants. Number two, complications from the ring. The patient cannot have a complication and stay home. When they have a complication, erosion or stenosis, the patient comes in because they throw up, the family looks at them and says, go do something. Whereas if you have a malabsorptive procedure, the patient is eating, but just getting smaller and smaller. And sometimes they love the fact that they're small, even though the albumin is going down to 1.9. And by the time they show up, they are in liver failure and it's too late to do anything. So that is the beauty of the ring. And again, as Dr. Neto showed, most band complications can be handled endoscopically. And in the United States, where the cost of surgery is so high, endoscopic intervention is cost effective in patients who have the ring. I want to thank the faculty. I want to thank Dr. Bhandari. I want to thank our commentators for participating in this virtual Bariatric University session. And we have another session in a week. And do we have the promo for that session, Winnie? No? Okay, we don't have it. So I think next we will be talking about the banded one anastomosis gastric bypass. Is there an indication to band the pouch in the one anastomosis gastric bypass? Thank you very much. Have a good day.
Thank you.
Thank you.
Thank you.
Thank you.